Dear friends, colleagues, and students, very good afternoon. On behalf of the panelists, I would like to thank everyone for making the time to attend this webinar. This webinar is organized by Ellerslie Center for Nursing Studies, National University of Singapore. I'm Wen Ru, the Associate Professor from NUS Nursing. I'm the moderator for this webinar. First of all, I would like to invite Professor Emily Ong, the head of department, to make an opening speech. Prof. Emily, please.
A very warm welcome to our webinar. Thank you for your support. I'd like to introduce briefly our department to all the participants. Our department is known as the Ellerslie Center for Nursing Studies. It is within the Yong Loo Lin School of Medicine, National University of Singapore. NUS is Singapore's flagship university and a leading global university centered in Asia. We offer undergrad and postgrad programs and have a total population of over 1,000 students. Our research program covers the following: chronic illness and long-term care, women and child health care, patient safety and quality of care, geriatric care, and wellness. I hope that you can go to our website to learn more about our department and our research program, and we welcome all of you to collaborate with us in the future. Let me once again thank you for participating in this webinar, and I hope you have an enlightening one today.
Thank you, Prof. Emily, for your introduction to our research and education programs. If you are interested in our research and education programs, you can always visit our school website to find out more information. Okay, now let's move to our today's session on the topic of promoting salutogenic capacity among healthcare workforce for health promotion in community-based care. So we are very honored, to have three speakers: Prof. Gill from Norwegian University of Science and Technology, Associate Professor Magdalena from Medical University of Warsaw, and Dr. Bessie from NUS Nursing, to share with us about their projects and the application of salutogenic model for health promotion. So throughout the session, you can always ask your questions at any time through the Q&A function at the bottom of your screen. So the panel will answer your question at the end of the session. Okay, so before I hand over the session to our speakers, I will just have a very brief introduction of salutogenic model. What is salutogenesis? The word salutogenesis actually comes from the Latin salus, meaning health, and the Greek genesis, meaning orange. So Antonovsky, who is the father of salutogenesis, actually developed the term from his studies of how people manage stress and stay well. So unlike pathogenesis, which actually studies the causes of disease. So salutogenesis basically refers to the oranges of the health and focuses on the factors that support human health and well-being rather than on factors that cause disease. So from the salutogenic perspective, so instead of perceiving health as a dichotomy, labeling a person with presence of a disease as fit and a person with absence of disease as well, health is best understood as a continuum, like a line. So according to Antonovsky, each of us is on a different position on a health is or disease continuum, whereby one end refers to maximally ill and the other end refers to maximally well. So from the salutogenic perspective, we live in an environment of constant stress and disorder. So we actually encounter them every day. Stressors could be our daily hustles, such as getting your children ready for school and not to be late, keeping your dried clothes before leaving the house, or even posting on Instagram to keep your fans, followers updated, or maybe catching the specific time slot for online sale of items. So sources of this stress can be internal, such as not meeting your own expectations, fear of being late for work or school, or these sources of stress can be external, such as you lost your loved ones, or being infected with COVID, or playing in a competition, or even rushing to meet your assignment deadlines. So regardless the type and magnitude of stressors, in face of a stressor which creates tension in the individual, he or she can either successfully cope with it or overcome the strain and move towards salutogenesis, which is the health is poor, or cope with stressor poorly, which result in breakdown of person and move towards pathogenesis. So conceptually, salutogenesis can be defined as process of movement towards health and of a health is or disease continuum. So essentially, the salutogenic perspective looks at the narrative of a person holistically. So it focuses on the strengths and assets of a person. It assumes that stresses are health promoting and well-being is generated through active adaptation. Salutogenic model is basically a stress resource coping theory. So there are two main concepts included in this model. These two concepts are the generalized resistant resources, GRRS, and sense of coherence. GRRS basically refers to characteristic of a person, a group, or situation which facilitate effective coping of tension caused by stresses. Whereas a sense of coherence is a life orientation in pursuing life as a comprehensible, manageable, and meaningful. So a person with strong SOC perceives life as a comprehensible, manageable, and meaningful. So he or she will have trust in self to identify resources needed to develop strategies in resolving issues, thereby facilitating active adaptation process. Okay, so improved health literacy is actually the key outcome of health education, which means we aim to educating people how to swim up the river. This requires the individual to be an active participant in using personal, social, and community resources, as well as physical capacities to swim upstream. Okay, so on health outcomes, actually, our health outcomes are based on our life orientation and the learning through our experiences to mobilize resources in navigating for a better quality of life and well-being. So the health process is actually a learning and developmental process. Okay, so to conclude, Salutogenesis is actually a stress resource-oriented coping theory, and it includes two main concepts: sense of coherence and generalized resistant resources. So from salutogenic perspective, health is a process, not an endpoint. It requires mindset shift from disease-focused to health-focused, to embrace moments of challenges and difficulties, and to harness strengths and resources of an individual. So actually, due to the time constraint, I'm not able to go in very detail for this model. So you can actually refer to this ebook to understand more about the Cellulogenic model of health. And anyway, today we are very fortunate to have three speakers: Prof. Gil from Norway, to share with us about his topic on the paradigm shift to cellulogenic health practice, opportunities and challenges in community care. Prof. Magdalena from Poland, she will actually share with us about her topic on the enhancing general practitioners' competencies in communication to older adults. And Dr. Bessie from our own department to share with us about his topic on introducing the application of cellulogenic theory in community-based setting to nursing students. Okay, without further ado, I would like to invite Prof. Gil to share with us about his topic. Prof. Gil, please.
Thank you. Thank you very much, and thank you first of all for introducing me or having me as a part of your webinar. And also thank you to Venru for this beautiful way of explaining us about salutogenesis. As Venru said, my title for today is a paradigm shift to salutogenic health practices, opportunities and challenges in community care. My presentation is a bit on different topics, but first of all, about what is the topic for this presentation, and secondly, what is the impact from salutogenesis on what we are doing now, especially in the municipality. I'll be a bit back to that. But who am I? I've been a professor of psychology for many years at our university. I've been head of department. I've been a founder and leader for the Antonovsky Center for Health Promotion Research. And that's where we came into the theory of salutogenesis, where we started to work with salutogenesis. I also have a political career. I've been working in politics for many, many years, and I'm a deputy member of parliament in Norway. And I'm today, but still a
Sorry for the internet issue.
Okay, seems like I have a problem to get the slides shifting, but my next issue was going to talk a bit about how how I became the mayor of this municipality, and I can tell you a bit about the campaign we were running, and it is co-creation. How do we make a municipality better for everybody, and how do the citizens be more involved? We are working on creating district health center because we didn't have that before. We have for care, but not for health. So we are working on a greener municipality. But the main thing for me is, of course, to shape the public health. How we are working with public health? Just a fun fact at the bottom, because Uppdal is 2,470 square kilometers, and I know that Singapore is 720 square kilometers. So this is a huge municipality also compared to Singapore. Well, we'll need to change to the next slide. So what is the topic? Well, let's start with this new reference to an article from 2015. Let's start here. We anticipate that the next 25 years likely will be packed with as many advances in our understandings of health and the influence of lifestyles as wellness as the past 25 years. So we know that a lot of things are going to happen on how we view health in the future and in the next 22 years. This is an old from an old article written by Jeffrey Rose in 1985 that shows how we will have to better the health of populations. We need to. It is about my next slide was about public health and its part and how it's defined. Public health is the health of the population as a whole, especially as the subject of government regulation and support. That's from Oxford Dictionary. And so you see that public health is divided in two parts. And it is disease prevention and it is health promotion. Disease prevention has to do with not getting diseases, avoid getting diseases, and health promotion has to do with how do we promote our health. What, like when you said in Salutogenesis, it reflects the ways that we are working with the health. Public health, our understanding, is it two sides of the same coin? Or is it one side at the same side of the same coin? You see, in Scandinavia, we define health promotion and disease prevention as together being public health. Much more, I think, much more than in many other countries. We are looking at this at the same side of the coin. And in the next, you will see that I have tried to show that by showing you a Singaporean dollar. I found this some days ago at the website of the NUS. NUS fosters healthier communities by researching on diseases and health threats to inform on interventions and policymaking. Faculty members are also developing innovations that impact public health. So, how strongly is health tied to diseases? Is health really a part of diseases, or is it something outside having a disease? And of course, most of us believe that health is much more than having a disease. So it doesn't really matter whether you have a disease or not. But to health promotion is part of the whole agenda when it comes to health. So here we work on health rather than only avoiding diseases and threats. Salutogenesis, as we have told, is about increasing importance due to demographic changes when it comes to how do we create health systems that are sustainable? How do we work with more health promotion in populations? How do we build resources into individuals, families, and societies? We know that New Zealand actually have a law now that says that they will be accounting for health and especially for quality of life when it comes to enhancing health. The departure point for health promotion and the departure point also for salutogenesis is to try to find what is the assets of well-being. The assets of well-being is, as you saw in the bowl that quickly passed by us, it is about all these things that develops health rather than getting us to think more on how to avoid diseases. So health promotion is in all the different facilities or all the different ways that we are working with health. So both in prevention, treatment, and rehabilitation, we are working with health promotion based in salutogenesis. As Venru showed us, there is a textbook that gives us the insights into what health promotion is and how it is worked with health promotion. And as you also said, that salut is from health, is a Latin for health, and genesis is Greek for origin. So this is a theoretical concept launched by R.N. Antonovsky, as was told by Venru. There's a new textbook that have just come out in 2022 that is a new edition of the. So a bit further to how we use salutogenesis in Norway. And to analyze the use of and impact from salutogenesis in Norway, need to reflect on how it is included in and impacts the Norwegian health and healthcare system and how it became so. In 2007, we really started this in Norway. We started to use salutogenesis as the background for enhancing health in the Norwegian population. And we also have to say that then it started to become a part of the health policies. And you that came in 2000 came into one important way to work with health and to promote health in Norway. And we do it in different parts of the Norwegian system. We do it in the educational system. We do it in the system for practitioners, I mean the practical level, the bureaucratic and political systems. We do it in the organizational systems, and we work on it in most systems taught with the HP framework. And we talk about the health promotion and salutogenesis as a resource framework that we can work with health on. If we go to the educational system, we saw from 2009, but that we got a cross-disciplinary course that that used salutogenesis as the theoretical point of departure point. And we have more and more salutogenesis in the total curriculum of universities in Norway, and we have a network for how to teach salutogenesis and how to teach health promotion in Norway.
Prof. Gear, we have turned off the video because the bandwidth is too low, but we just want to continue with audio, and we'll follow you on the slides.
So that is the educational system that we have seen. And when it comes to the practical level, let's have the next slide. The practical level, the use of the salutogenic knowledge is evident in all kind of the practical work For example, in public health nurses, they use the salutogenic level when they are talking with kids and their parents. The general medical practitioners use salutogenesis and health promotion. We see that in nursing homes, and we see that in hospitals, and we see it more and more so in hospitals, that the theoretical framework of salutogenesis is in use. When it comes to the organizational level, in 2009, we started an Antonovsky Center for Health Promotion Research, where salutogenesis is the theoretical basis for what we are doing. And we also then got the first professor of salutogenesis in the world. Of course, that was a statement to the rest of the world that we use salutogenesis as a basic when it comes to how we are addressing it theoretically, addressing health theoretically. We have the network, as I mentioned already, for health promotion, research, and education, and we also have built up a European network for that. The Health Directorate became very interested in salutogenesis in around 2009 when I met them in Geneva, and we were talking about health promotion, disease prevention. And so the Norwegian Health Directorate became very, enthusiastic about using salutogenesis and health promotion more into policy. We have the Norwegian Institute of Public Health that is using health promotion and very concerned with health promotion and salutogenesis. And we have colleges and universities teaching health and healthcare more and more, so as I said. And in bureaucracy and in politics, we see that public health coordinators in our country, who is often most often the part of the staff of the municipality director, is building down silo thinking between disciplines more and more to help disease prevention be a secondary thing, and health promotion and salutogenic thinking a primary thing when it comes to how we are working in our in a society to be more and more health promoting. We see health in all policies more and more. We see that health is taken in all ways when it comes to different political and policy making. We see also that salutogenic thinking and theory is always included in public health white papers in Norway. So in contrary to how it was before 2009, it is now included as a part of every white paper that has to do with public health. We have also been so lucky to work with the Alice Lee Center for Nursing Studies and Venru and Betsy and others in the department for many years, and building together with them research curriculum. And also always, of course, what are the resources for good health. Then I will try to put the highlight on 3 projects that is kind of exemplifying how we are working. Next slide, please. In Europe, we have been working with a big project called Inherit Your Future. This is on health in society, both building down the silos between the different health professions, the different health themas and topics, and also building down the silos between the different parts of our government system, so that health is becoming an inherent part in all of this. As probably Magdalena from Poland will come back to we have been working with health in context. How could health be? How can we work with health promotion and with the basis of salutogenesis when we are working with general practitioners? That is in Poland. We have been working with Venru and Betsy in health in a time of changing demography, because we see more and more people getting older and older. That makes it necessary to think about how we can work with health in older populations. And it's been really, really fun to work with my colleagues in Singapore about that. So it has always been about how can we close the gap between practice and evidence. And then we have come to that health promotion research is very often health implementation research. And when we are working with salutogenesis, it's the implementation is the focus for us. We have a lot of different research on what to do, but it is less known how to do it. How can we implement it? And the project with Venru and Betsy was a good example in Singapore that how that could be done. And the way we are thinking is that we have the theory, we have the research questions, and then we go through intervention research, to translational research, to implementation research, and by this way we are building new practice. So there's a row of thinking here that's very important. Next slide, please. And we made the Trøndelag model, which is a model for how to use the theoretical framework and the new research into practice, and together with citizens and also other like voluntary work. How can we work to get the society more health promoting, and how can we do that by salutogenesis? So the impact from salutogenesis. We are trying to build a salutogenic government, and since I became a mayor, I have, of course, an indefinite number of employers. It feels that every citizen is my employer, and I also think that every citizen think that they are my boss. So we are trying to use that power of and invite them to be helping us with building better health and better ways to work with health in our society. So what I've been working with the politicians about is that all the political boards is not a place for it's not battlefields, it's not political battlefields, but we have the responsibility together to make health better in our society and for our populations. So we are also rebuilding parts of our house where we are living as the mayor and deputy mayor, as you can see on the picture. So we're rebuilding things so that it be easier for the citizens to come and work with us. So public health is an inevitable part of that. Public health has very often been run by MDs, and we see more and more that's not the truth. And public health, especially health promotion, is more run by public health specialists or by health promoting specialists. So we set out to change public health to be more research and knowledge based, especially with emphasis on health promotion, to be further developed in collaboration with a university, to better couple the other health services in the district health center, and to influence leisure time or cabin and holiday home owners as part of public health thinking, because we have a lot of holiday owners in our municipality. So how do we make it more knowledge-based? Well, into March 2020, I signed an agreement with the Norwegian University of Technology and Science about how can we build competencies in developing more and better public health and a better development of our municipality as a whole. We have since then had more than 50 research and other projects together with the university that help us build a better public health. So we are trying to build a public health center, a district health center, and this we are doing together with the specialists in public health and in health promotion at the university. So we are working with building this as a center where we can work with diseases, but on the total public health agenda. It's hard to get medical specialists to the district health services. That's what we have seen so far. So we are far away from a big city, even if we are in the middle of a small city. So we are trying nurses to see the patient and the specialist doctors to sit elsewhere and have digital information. So that is a way also of helping the three parts of the sustainability goals towards a better health. We also see that there is a huge challenge in all countries how to better inform bureaucracy and politicians of new knowledge in the public health area. And I've set up here at least 4 things that we need to do as researchers. We need to get more attention to the point information. We need to get to the point information. Very often we are using too many words. We are using too difficult words, and we need to make it ready for decision making. We need to be more communicable. More information need to be more easy and with a better understandable language. But most important, we need to make meeting places between the bureaucracy and politicians and the researchers so that we can present what is new in these events. We also need to be tough enough to invite ourselves to political parties, to political arenas, dare to be bold. So the take-home message from this lecture is that society is changing, demographics are changing. There is no way that all health challenges can be met only with more disease prevention, more treatment, or more rehabilitation. We have to think differently. We have to think in a different paradigm. Our view on health and our medical paradigm is shifting and includes the knowledge of finding and building resources and strengths of individuals, families, and societies. That is, in a way, what health promotion is about. That is what salutogenesis is about. More resources, more strength, both in individuals, families, and societies. And that's the end of my lecture. Thank you. And you can find my 2 different mail addresses here, as I guess that the whole lecture will be possible to download. At least the slides will be possible to download. Thank you, and I am sorry that we had some issues with the transference of or transferring my lecture, but thank you.
Thank you, Prof. Gil. Prof. Gil, sorry, we have to off your video because the internet is really unstable. Okay, so anyway, thanks for Prof. Gil's presentation, and then maybe just, I think I refer to his last slide. It's just some taking home message, So as mentioned by Prof. Gil, that our society and its demographics are consistently changing. So there is no way to address all the health challenges just through increasing disease prevention, treatment, and rehabilitation. So our perspectives on health and our medical paradigm are evolving to encompass the knowledge of identifying capacities in individuals, families, and societies, as well as developing their resources and strengths. So salutogenesis actually offers a theoretical direction for us. Okay, and so I think we will move to our next speaker, Prof. Madlina. Prof. Madlina, I over to you.
First of all, I would also like to thank you for a nice invitation and possibility to participate in this wonderful webinar. I will be talking about something a little bit more specific or kind of narrow in comparison to the professors before me. And I would like to concentrate on something that's on one of the things that Sker already mentioned. Talking about enhancing general practitioners' competences in communication to activate or make the older adults more active would be this practical aspect of teaching salutogenic approach in a little bit of an indirect way. But for start, I would just very briefly introduce myself. I'm a health psychologist and associate professor at the Department of Health Psychology at the Medical University of Warsaw in Poland. I also have the pleasure to be the head of our university counseling services. And I used to work for a good couple of years as a health psychologist at the clinical ward of surgery and parenteral nutrition, working with a number of doctors with better or worse communication skills and quite a big number of older patients that were the patients of this clinical ward. My major research interests concentrate on quality of life and well-being of the somatic patients, older adults, and young people, especially university students, and the ways of expanding general health and the mental health resources in these groups. As for my teaching experience, for the last 15 or so years, I teach medical psychology and medical communication courses for nursing, physiotherapy, medicine, and dentistry students, and both topics concerning the health of older adults and communication, medical communication in general, are a big part of this teaching experience. And talking about older adults, I won't be getting into the details of this charts because I guess they are well known in the setting, but just to get briefly on that, and also mention it a few minutes ago, that well, I guess we are all well aware nowadays that we are living in aging societies, and that well, we can't anymore talk about the population pyramid, or we rather talk it turned upside down, right? We are talking about the turned pyramid in the context of the population, and that by year 2065, the population support ratio will drop to 1.2. And that calls, or rather screams, for the for critical changes in the way we work towards our health. So it screams for the increasing chances of health, healthy, successful, and active aging, because simply there won't be too many to look after us when we reach the older age. This stays in line with the WHO's recommendations, or this can be achieved following WHO's recommendations, which are to minimize the consequences and preventing chronic diseases, to promote health and healthy behaviors, create environments that help to maintain health and active participation in social life, and by changing social attitudes to encourage the participation of older people, participation generally in life. When we think about active aging in this context, and again, when we look at it through the eyes of WHO's recommendations of our active aging policy framework, you can see that, of course, there are multiple determinants of active aging. What I would like to concentrate on are the health and social services, behavioral determinants, and personal determinants of active aging. And these personal determinants include, of course, many other things, but also self-efficacy and coping styles. I believe that health and social services may be also an important factor that can impact behavioral determinants, so how we act, for example, healthy habits, and personal determinants. So, in other words, that healthcare providers may help out in behavioral change and developing personal resources, and so that they, in turn, can lead to active aging. And when we think about active seniors, they, of course, again, can be defined in different ways. But one of the ways to look at that in the context of health, in the context of healthcare, would be to think that an active senior would be a person that has an active attitude towards illness and treatment. So searches for information on illness and treatment, participates in decision-making regarding treatment, etc. This would be a person that has the active attitude towards health. It would be a little bit more than just towards treatment and illness, as a salutogenic approach here. So that's a person undertaking protective behaviors like vaccinations, eliminating harmful behaviors, introducing health behaviors, so working towards building up the health resources. And that would be a senior that have the active attitude towards life, and participates in social relationships, goes on accomplishing one's goals, undertakes professional and social activity towards better quality of life. And it seems that general practitioners may play a distinctive role in promoting active aging. General practitioners seem to have the current knowledge about problems of elderly patients and aging processes, factors depleting or contributing to good health. They are a profession with high social trust and respect, which of course increases the chances of an impact. Senior patients during the visits at the GP's office are potentially pre-motivated. They are interested in their health. They appeared in the office, so the chances of building up motivation towards a change is already kind of there. Not always, but still, chances increased. Also, GPs may have may play an important role in supporting seniors in isolation or loneliness. They have better knowledge about patients and their families than other specialists who do not see them as often as others. Doctors may also have good recognition of senior needs and expectations. They also may have social attitudes fostering the activation of older persons, and they may have the skills to communicate and motivate seniors towards more active attitudes. And I stress the word may, because this is also a part that it is a little bit unclear if they actually do, and that was and to investigate that a little bit further was the goal of the already mentioned PRACTA project. That was a Polish-Norwegian collaboration with our colleagues from NTNU, and that was a grant from Norway grants, and the full title of the PRACTA project is Promoting Active Aging in Public Healthcare, Recognizing Patient Psychosocial Needs, and Enhancing Doctor Interpersonal Competencies. And toward the end of the presentation, that's what I would like to talk a little bit about. So show you some of the results and experiences within this project. The PRACTA project was conducted in Poland and all data was collected in the central divisions of Poland, and the numbers that you can see in the boxes are the numbers of the facilities that were finally included in the project. So the facilities where we studied doctors and patients in the two waves of the study. So we started with asking a group of doctors to fill in the questionnaires, a set of questionnaires, including the communication skills, where the doctors try to answer on how they usually act towards all the patients, and the attitude towards treatment and health scale, including also the self-efficacy scale, where the doctors were answering questions on how they think that 65 plus patients usually act after they visited them. And we also asked these doctors' patients to fill in two sets of questionnaires. One before they came into the came into the office to see the doctor, and the other when they were leaving. So before they were entering the office, in that set of questionnaires included the communication scale, where the patients were answering the questions on how important it is for them that the doctor behaves in a specific way. And when they were leaving, they were asking on how they feel the doctor actually behaved. And upon the leave from the clinic, they were also asked how motivated they are. So they were also asked the attitude towards treatment and health questions, including questions on after the visit, after this visit, I behave this or the other way. We had a 1 year gap later with the intervention there, and we came back to the clinic. We studied the same doctors and a new group of patients, but with the same questionnaires. And as mentioned, in the between, we had an intervention about which I will speak in a moment. This practical communication scale that I've already mentioned had 26 items asking about specific communication behaviors that were based on Calgary-Cambridge protocol and good practices in doctor-patient communication. So, for example, they were asked, like during visits of my elderly patients, I greet them in a kind manner. And the patients were asked how important it is for you that the doctor greets you in a kind manner. And after the visit, they were asked, all right, and to what extent are you happy with how the doctor greeted you with kind manners? And so we had this three measurements to be compared. And from the first wave of the study, what we could have seen was that our patients had pretty high expectations, and that's the blue bar on the left chart, And the expectations were higher than were significantly higher than the experience during the visit. Doctors' opinion about their own communication was unfortunately closer to the patient's expectations than to the actual experience during the visit. And here, the difference between the doctor's assessment of their own communication skills, that's a yellow bar, in comparison to the violet one, which is the patient experience, was also significant. We were also checking for matching expectations to experience, and we can see that almost 80% of the patients' expectations were higher than experience. In case of about 5%, the expectations equal the experience, and only in case of 15% of the patients had lower expectations than what they actually got and received. The other scale that I've already mentioned was the scale of patients' attitude towards treatment and health, and you can read a paper on this scale if you would like to. That's also shown on the screen. This is a questionnaire that has 4 subscales on knowledge, motivation, positive and negative emotions in the context of health and treatment. So, for example, I undertake the results and I understand the results of all medical tests. I'm going to comply to the recommendations. I feel calmer after this visit, or I feel depressed or have fears about the symptoms after this specific visit, or my patients usually have after the visit. And as mentioned before, we often add the self-efficacy scale when analyzing the patient's active attitude. And one of the analyses in this context was looking at the profiles of health proactivity of the seniors, and we could, as a result of the cluster analysis, we recognized 3 different profiles of older patients in this context. So we have this high proactive profile with patients with high knowledge, high motivation, high self-efficacy, high positive emotions, and low negative emotions. And then we have the medium proactivity profile, where everything is kind of in the middle, and a low profile similar to the middle, but with lower results and everything, including negative emotions, but also kind of positive scales. So after recognizing these profiles, we checked how the patients with these profiles differ in the context of the medical communication. And what we can see is that patients with high profiles, so the patients who are highly proactive, and also had highest expectations towards medical communication, but also the highest experience, and the discrepancy, the difference between expectations and experience, was the lowest in this group. While in the context of the low proactivity patients, they had high expectation, low experience, hence the discrepancy was pretty high. Thinking about this experience, we built our intervention. So based on that knowledge from this analysis and more of them. So we built the Practa e-learning model, Practa e-learning, which had 5 modules. It was evidence-based and professional knowledge-based. We tried to make it as attractive as possible with short movies, videos, podcasts, and it also had the elements of gamification. So the participants were receiving different missions to carry out to, through that, learn about healthy, active, and successful aging and medical communication. And the other group received a PDF article intervention, which simply summed up what was in the e-learning, but in the form of a more traditional kind of, book chapter. It was still kept attractive visually, but it didn't have all these additional aspects. And we had the control group that I mentioned that received all that, but of course later after the intervention. And what we can see from the selected PRACTA post-intervention results was that both forms of this intervention brought beneficial changes in general practitioners, but the effects were interestingly different. So the e-learning influenced mainly an improvement on GPs' perception of seniors and their evaluation of own communication skills. So they felt they got better in communication after this intervention. While the article affected mainly general practitioners' evaluation of their own communication, but in a negative way, in the sense that they became more critical. So their communication skills dropped, but it wasn't the skills, it was actually them realizing that they are not doing everything right, but they did not improve the link, how they act, or the patient's perspective on that. And the patients, the other interesting result was that an increase in self-assessment of communication behaviors is positively related to an increase in general practitioners' perception of an active attitude among older patients. So if I feel I'm better in communication, I also see my patients as more active. And both types of PRACTA interventions exerted an impact on GP's perception of the attitude of older patients, and change in this perceived communication behaviors of GP could be considered as a mechanism driving this effects. To conclude, it seems that doctors underestimate the expectations of senior patients and overestimate their own communication skills. A patient with a high expectations and good experiences during the visit is potentially an active patient. So this may be this demanding patient, but actually this being demanding seems to be a good thing, and that changing the way doctors communicate may have a therapeutic effect. So through the activation of patients, but the way we teach medical communication should be based on the combination of knowledge delivery and modeling of communication skills. So rather, the impact of the e-learning than just passing the knowledge, because it doesn't really necessarily has to be known how to implement it further. And if you would like to learn more about the PRACTA project, here are a few of the publications that I'll be happy to share, and also to answer all of your questions. Thank you.
Thank you, Madalena. Yeah, wonderful study. Yeah, we can see actually from your last slides, you have published so many papers. So yeah, maybe just a very quick summary of Madalena's presentation. So as shared by Prof. Madalena, where general practitioners appear to be good actors for getting older adults or patients to be more active, improving general practitioners' competencies in medical communication is needed first. So medical communication training must be delivered in a specific manner through knowledge transfer and the modeling of practice. So offering knowledge such as just through PDF intervention is actually simply insufficient. Okay, again, thanks Prof. Madalena. Okay, now I just hand over to Bessie. Bessie, please, your turn.
Okay, thank you, Prof. Wang. Okay, greetings to everyone out there at the opposite side of the screen. I'm Betsy, a research fellow from Alice Lee Center for Nursing Studies, National University of Singapore. So just a very quick introduction about myself. I embarked on my research journey on salutogenesis together with Prof. Gill and Prof. Wenru during my PhD, whereby I developed a salutogenic-based healthy aging intervention for older adults. And my research interest remains in the application of salutogenic theory in health education as well as in practice, together with research related on health promotion among community-dwelling older adults. So apart from research, I also have been teaching various academic modules for pre-registered undergraduate nursing students since 2016. So here I am going to share with all of you on our experience of introducing this application of salutogenic theory in community-based settings among nursing students. So as our speakers have shared, Prof. Madalena has shared, globally we are facing a rapid aging population. So by 2050, the world's population of people aged 60 years and above would double from 1 billion in 2020 to 2.1 billion in 2050. So as medical care advances with the rapid sanitation, people are living longer with rising prevalence of non-communicable diseases. And in 2019, the top 9 leading causes of disability among the 50 to 75 older individuals were non-communicable diseases. As you can see here, ischemic heart disease, stroke, diabetes, lung cancer, and other chronic conditions in the lungs, liver, and kidneys. So with all these changing health trends, there is a great emphasis on longitudinal and holistic care, as also shared by Prof. Gill, right? And there is this need to improve on health-adjusted life expectancy and quality of life by cultivating healthier lives. So we have to move beyond disease management in acute health settings to health promotion, disease prevention, and even patient empowerment in community settings. So the role of healthcare professionals thus have to move beyond disease prevention and management to cultivating healthy lifestyles among the general population so as to improve their well-being and wellness. So salutogenesis, as Prof. Wu has shared, it is a resource-oriented approach which focuses on health creation by coping with stresses effectively. So its outcomes focus on proactive, upstream, and adaptive measures in health production, which leads to better coping and self-care capacities among individuals. So care systems to adopt salutogenesis, healthcare professionals, including nurses, first, they have to understand and develop the salutogenic orientation as well as the salutogenic capacity to practice. So in response to the Singapore Ministry of Health paradigm shift from healthcare to health, an educational strategy on healthy community living module was incorporated into our pre-registration nursing curriculum in 2020. So we introduced the salutogenic theory in this module to our second-year undergraduate nursing students, as well as our first-year career conversion program nursing students. This module was offered as a compulsory module as part of the core curriculum. So in this module, students underwent e-lectures to learn about the theories, concepts, and they also had to attend a virtual workshop to learn about the application of salutogenic theory for people of different age groups in the community. And during their weekly tutorial sessions, we'll have to work in groups of 4 to 5 to develop a sustainable health promotion intervention using the salutogenic orientation. So they are being assessed by a group presentation as well as an individual written assignment on their group's proposed health intervention. So each group of nursing students would have to decide on their target population age group as well as a health topic to work on. So these are just some examples of health topics which they can choose from, and students had to adopt the salutogenic orientation to develop a health intervention. So while this is an educational initiative to develop the salutogenic capacity among nursing students, the development of salutogenic orientation and capacity will have to be strengthened over time in one's nursing career. And having to understand how the salutogenic orientation and inquiry could be inculcated and developed will be important in advancing future salutogenic practices in the community. So as such, we actually conducted a research study to explore nursing students' perspectives on utilizing salutogenic theory in the community for health promotion. And this includes illuminating the understanding of salutogenic theory, exploring the scope of the theory application in community nursing, as well as identifying perceived benefits and challenges in utilizing the theory as a health promoter in community nursing contexts. So this study adopts the qualitative study design using a framework analysis. It uses 5 domains of knowledge framework from the IB program Theory of Knowledge as conceptual framework to explicate nursing students' understanding of the theory. Nursing students undertaking the Healthy Community Living module were invited to participate in the study, and we developed a semi-structured interview guide based on the 5 domains of knowledge framework. 4 mini focus group discussions involving 18 nursing students were conducted online, and they were video recorded and transcribed verbatim. Additionally, to obtain a comprehensive understanding of students' comprehension towards the application of the theory, we also analyzed their written assignments, and a total of 32 students agreed to have their written assignments anonymously analyzed. And finally, the framework analysis using matrix-based method was being used to analyze the data deductively to create a thematic chart, themes, and subthemes. So this is an example of how the 5 domains of knowledge framework was being used as a conceptual framework. So if you take a look here at the left, these are the 5 domains, which is scope and application, language and concepts, methodology, historical development, as well as links to personal knowledge. So all 5 domains serve as consideration to develop different ways of knowing among students. And for example, in examining language used in the production of knowledge and how concepts are being communicated, we actually asked the participants during the focus group discussion on what they have learned about the theory, and we also examined the language as well as the application of the concepts. So this figure actually illustrates the thematic map of findings. So due to the closely intertwined domains in the knowledge framework, you realize that the themes and sub-themes are not organized into the knowledge framework, but it actually addressed them to address the research questions in a broader perspective. So the 4 themes are reorientating healthcare for healthy living communities, ambivalent learning, attracting early adopters of salutogenic paradigm, and as well as practices for positive health development in complex systems, future directions. So the first theme here, reorientating healthcare for healthier communities. This theme actually illustrates the scope of application of the theory in the community. So participants recognize that there are diverse opportunities of practicing salutogenesis. It can be applied across different age groups on different health issues in both healthy populations as well in the community as well as in different healthcare settings. So one of them actually shared, I realized that the salutogenic model can be applied to almost everyone in almost every setting. Participants also realized that the practice of salutogenic concepts is already out there. And it's just that we are just putting a term on it. So they learn to understand health behaviors from non-medical aspects of care, drawing from past personal as well as clinical experiences. And one of them actually mentioned that we already knew this mindset, but the module actually strengthened the idea and taught us more in depth. Participants highlighted that the salutogenic approach allows them to understand patients at a deeper level with a bigger picture, with a big picture thinking perspective beyond diagnosis. So one of them actually shared that, you can think of it like a patient profile, a history-taking exercise. You can understand the patient's background, or the factors surrounding their life, social resources that they have, what coping skills they have, what kind of mindset in tackling this challenge, and it's part of the model. So with this big picture thinking, participants reflected that the salutogenic model actually helped them to identify patients' unique health needs and to decide on what is important and workable for them. So this actually allows for tailored healthcare. So one of them actually gave the example from the pathogenic perspective they will just give standard treatment regardless. But if you understand the patient's background, they may not get the ideal treatment, but it may actually work for them. Some patients might not be able to afford the healthiest food, but they can change part of their diet to something healthier that will affect their health positively in the long run compared to not changing it at all. The second theme, ambivalent learning, illustrates participants' challenges in learning the salutogenic theory. So through the assignments and narratives of personal experiences, participants showed that the capacity to align with salutogenic thinking. So one of them said, no, salutogenesis is something I need to consciously think about. It definitely needs time for you and maybe other nurses to start talking in this manner, then everyone will slowly get influenced. So some participants struggled with the salutogenic-oriented language. They misinterpret salutogenesis application as an expression of wordplay and optimistic messaging geared towards positivity. So, but some of them also demonstrate the lack of comprehension and assimilation of salutogenic theory and concepts. So they had limited knowledge translation into personal mastery, and one of them shared that the only way I know how to use this theory was in my project. So to improve on knowledge translation and personal mastery, some of them actually suggested, having community nurses to share on their work experiences, provide specific relatable examples in applying salutogenesis in their everyday lives. The third theme, attracting early adopters of salutogenic paradigm, actually illustrates the challenges of adopting the salutogenic paradigm in professional practice. So participants highlighted that the entrenched pathogenic-oriented mindsets as a key challenge. Some of them expressed difficulties in accepting the concepts due to traditional biomedical education on pathogenesis and curative treatment. Few of them shared that the presence of medical dominance as a barrier for nurses to offer salutogenic care. So one of them said, for salutogenic theory to work, we nurses must believe it. So findings indicate that adopting the salutogenic approach in clinical and community settings is resource intensive and extensive. Providing salutogenic care actually requires a lot of time as well as genuine personal connections by observing and listening to patients. However, this could be challenging when nurses are overwhelmed with daily clinical tasks and manpower shortage. Salutogenic care requires engagement and support of nursing management. And that's why one of them said that, you have to start like a management level, believing that salutogenesis genesis will work so that they can structure nursing workload. Ground workers may have more time to spend with patients, like giving a structure and guidelines so that it's more feasible and attractive for healthcare workers to adopt this mindset and theory. So the last theme, practices for positive health development, future directions. This theme illustrates the perceived benefits of adopting salutogenic theory in community practice. Participants portrayed that the model actually helped as a reflection tool to provide mental clarity, whereby they actually use it to make sense of their own health experiences, stresses, decisions, coping mechanisms, and even motivation. So one of them actually shared, this is quite interesting. I realized surgeries only solve maybe 20 to 30% of the problem. But not to get injured again and reduce the risk of injury, you have to do a lot of physiotherapy. And injury is actually a negative state, and surgery returns you to ground zero. To go back to positive state, you have to put in a lot of hard work, and it is up to myself. So the salutogenic model offered the participants a creative and sustainable approach to health education. It allows them to put on new lens to identify issues from different perspectives in managing patient care. Nurses could use the model to raise awareness about patient stresses, coping mechanisms, resources, to encourage them to take small but actionable health actions. Participants also shared that the salutogenic model recognizes health as a collective responsibility. It utilizes and builds resources within as well as surrounding the patient, such as engaging family members. This shared responsibility empowers patients to take charge of their own health and even empowering those around them. Among the participants, there was also greater appreciation of interdisciplinary care since the model actually allowed for collective efforts from different healthcare professionals. So some key discussion findings. So findings from this study captured the nursing students' understanding towards the value and philosophy of salutogenesis, its theoretical utility, as well as the opportunities to transfer the theory in nursing practice in the community. So note that actually this content on perceived benefits and challenges, they are all based on the students' understanding, and they were not taught in the curriculum. So in fact, these students actually link their learned theories with their past personal and clinical experiences. So one key application of the salutogenesis identified by students was to use the model to obtain an overview of patients' health situation via comprehensive assessment. So this actually allows for person-centered and tailored care strategies. Findings also suggest that having to introduce salutogenesis into the nursing curriculum could potentially enhance nursing students' development of soft skills, such as having a broad view of things, being empathetic, as well as it make them realize the importance of establishing trust and relationships with both patients and other healthcare professionals. So the model also actually prompt them to reflect on their own health experiences and to even engage healthier mindsets and lifestyles. Findings also revealed that participants' ambivalent learning experience actually limited their capacity to translate knowledge into professional practice and personal mastery. So the entrenched pathogenic biomedical healthcare model that we have now actually accounted for their lack of familiarity and conviction in using the model. Participants also highlighted that the lack of concrete examples in applying the theory in the community. But that being said, our findings actually show that by introducing the salutogenic paradigm into nursing curriculum, it could attract early salutogenic adopters. So based on our findings, we actually make some changes to our module delivery. So during our virtual workshop, we actually introduced specific relatable case-based scenarios, such as in this video clip as you see here, to illustrate how salutogenic practices are being observed in the community in everyday lives. And we also provide more examples and steps in applying the various salutogenic concepts and principles in both nursing clinical practice as well as in community settings to help students relate theory to practice better. So our findings actually revealed that showed the value and versatility as well as usefulness of introducing the paradigm into nursing curriculum and perhaps in practice too. So salutogenesis offers an alternative perspective to healthcare delivery, and it allows healthcare professionals to engage in care practices in a non-medical or rather non-pathogenic manner. So at a community practice level, perhaps a systems approach would be needed to advocate and support nurses as early adopters to provide salutogenic care. So this actually include like endorsement of salutogenic-oriented care activities by management, the provision of guidelines on how salutogenic care can be delivered, as well as to cultivate salutogenic mindsets among healthcare professionals. The part on implications of future research, design of health empowering interventions could include like collaborative partnerships of nursing students as early salutogenic adopters to cultivate knowledge exchange and mastery of salutogenic concepts. So this study would not have been possible without my team. My colleagues here will have Dr. Sheena Ramadus, Mr. Tan Kwang Rong, right, Associate Professor Wang Wenru, as well as not forgetting Professor Monica Erickson, who gave her valuable input in salutogenesis for this study. So special thanks to our department for funding this project, and I'd like to thank all of my colleagues involved in the teaching of this module, as well as the nursing students who have contributed to this study. So thank you very much for attention, everyone.
Thank you, Bessie. We actually started this module in 2020. We have been running this module for 3 years. I can see, this study really, the findings from this study really provide a very good direction for us and how to improve this module. But we still see the challenges. The the module feedback is getting improving, but we still have to really work on how can we further improve this module. So maybe just a quick summary for Bessie's presentation. So basically, Bessie shared with us about the qualitative study, based on this module that we have been doing for our Year 2 nursing students. So as shared by Dr. Bessie, we can see salutogenesis actually can reorientate or demedicalize health delivery in community practice. So introducing salutogenesis into nursing curriculum can actually attract early adopters. It may enhance nursing students' development of soft skills and reflective practice. However, we do see the pathogenic-oriented mindset is really deep-rooted and pose a challenge to these early adopters. So still, we have to do more and actually how to introduce this concept into our nursing curriculum. Okay. Yeah, thank you, Bessie. Okay, I think we still have some time for the Q&A. I do see a few questions raised by the audience in the Q&A function. Our speakers can also see those questions. Maybe we start with the question for Prof. Madlena. Madlena, I think we see a question, very interesting sharing of your study. And may I ask, if you could share a little bit more about the topics under your modules for e-learning, and also why you have chosen to conduct e-learning instead of other methods such as face-to-face workshops. Madlena, please.
Yes, thank you for this. Thank you for this question. I really wanted to talk about it within the presentation, but there was, a time limit. so thanks for allowing me to answer that. So we had, as mentioned, we had 5 modules, and we've started with some brief theoretical introduction of such ideas like active aging and active attitude towards health and treatment. And that was the first module. It was, of course, also practical. And as mentioned, and there we presented some basics of medical communication. So what is active aging and how it can be achieved, through communication, why communication is important. Then we moved to more like the insightful model, where we were encouraging the doctors to analyze their own, we were presenting some data, but we were also encouraging doctors to analyze their own beliefs, stereotypes, and expectations toward older adults, and presenting some facts that are often in the contradiction to those stereotypes and kind of individual, well, not evidence-based knowledge. And there we were presenting a model. We're talking about barriers in communication. Then we moved to the actual importance of doctor-patient report for senior patients. And for the health outcomes in this context. So there was the data on that. And we moved to, in this practical aspect, we moved to more types and the scope of information that is needed to be provided, and what is active listening and non-verbal communication aspects. And we presented some protocols on how to act, how to work with the patients in the context of communication. The 4th module was on psychological skills for promoting active attitude towards treatment. And there we provided training for motivational interviewing and working with in motivation and the techniques in that. And we've summed the e-learning with the modules, with the broadest modules on quality of life and the meaning of social support and medical support towards the development of a very broadly understood quality of life in the context of senior patients. So how to activate them for better life, not only in the office, but to work towards it outside the office in the social context. And we chose e-learning. It was in the pre-COVID times, but we still chose e-learning instead of the workshops, simply because we know how hardworking and engaged our doctors are in the clinics, and we presume that that's trying to find a group, as big group of doctors who would come to work with us kind of in person during the workshops will be even harder than encouraging them to participate in the e-learning. And we also think that would be investing into creating an e-learning will be something that can be used then repetitively without additional costs. So we wanted to create a kind of a product that could be then implemented with other doctors, without the need of the actual teachers that would go and train further doctors. But I truly believe that in-person training could possibly be even more effective. Thank you.
Thanks, Madlina. Yeah, I think it's good that you start the e-learning before COVID, because after COVID that, we have no choice. Must go for e-learning. Okay. Yeah, thanks, Madlina. I hope that, Madlina has answered the question raised by Claire. Okay. Yeah. Maybe my next question goes to Prof. Gill. So, Prof. Gill, actually, I see. Sorry, Prof. Gill. Just now we have to off your video because your internet is really not stable. So, Prof. Gill, I see you are concerned about the need for a good talk between politicians and also public healthcare researchers. So, why is this the case, and how are we going to do it? Prof. Gill.
Since I started to work as a politician, I have been aware of that the distance from researchers to politicians and to the policymakers are quite long. When we find things that is new and innovative, it takes a long time till it comes to those who are the decision makers in societies. It's the same with that goes for all the central authorities, and it goes for community authorities. So I think that we need to find places, we need to find ways to communicate better with the decision makers. That very often is the politicians, but also the bureaucracy, the administration of the communities also need to get informed better. So I think that we the researchers have a responsibility to create ways to communicate better with politicians, decision makers in the different parts of the community or their societies. And we need to be aware of that all the technology, all the ways that we are expressing ourselves is a bit complicated to understand for, at least in most of the countries, for politicians that doesn't have the firm background of health. So that this is a really important thing for us as researchers to do, because as long as the politicians don't know about what innovative health that is now the new scene, we need to be the ones that both are creating the places to meet politicians. We need to make easy ways to communicate with politicians, because those are the decision makers after all. And also, as I said, with the administrations, we need to work in the same time, make easy to understand ways to communicate. But at the end, I would say that thank you for having me as part of this seminar, because I think also this is a way of communicating what we are doing around the world. We have now heard both Venru, we have heard Magdalena and Betsy telling about their research, especially when Magdalena and Betsy has told about research projects. But this is probably the most important ways to communicate across the world, to have webinars or seminars that we are joining to. And also, I think that we should have a webinar. How do we communicate better with the outside world? And then I'm talking about administrations and politicians, to be available for them to make the decisions for the future that we think will be the best decisions. Thank you.
Thanks, Prof. Gill. Prof. Gill, I see another question raised by Erin, maybe followed to my question. So actually he asked, could you also provide us with some specific examples on how your community of politicians and administration promote knowledge-based practice in healthcare, and how broad is your definition of practice? Thank you.
Well, let me start. let me start with the first thing, the broadness of practice. I would say that there's so many different practices involved in a community. It's the politician's practice, it's the administrative practice, it's the general practitioner's practice, it's the nurse's practice. All of these are practices. So we need to address them all. And the way we do that in our small community here is that we make meeting places so that politicians can meet with. And now, as I told you during my part of the seminar, we also have a agreement with the university, and the university people comes to our meetings and tell about the research projects that we do in together with between the municipality and the university. In that way, we get the newest information. They got the newest information about what is wrong or what is the challenges, and can help us to work further on. So I would say that making those places and also hearings about what we're doing, so that the university people can hear what we are thinking, what the politicians in our place is thinking about, what we should do to solve the health in better ways in the future, and to build down the silos between the different parts of the health system. So we are doing this in different ways, but I would say that being a part of the university system, like a municipality, has been helping us a lot. We have had 50 research and other projects since we wrote or signed the agreement in 2020, which shows that it is a lot of things that could be done by involving research better in developing health.
Yeah, thank you, Prof. Kier. I think how we as researchers or healthcare professionals, healthcare providers, we need to make our voice, being heard by the politicians, by the stakeholders. Okay, thank you, Prof. Kier. Yeah, I think my due to the time constraints, so my last question goes to Bessie. So Bessie, I think John asked, thanks Bessie for your sharing. Could you share how we can overcome, these challenges of the entrenched pathogenic-orientated mindset in learning about the salutogenic theory among nursing students?
Thank you, John, for the question. So, although the entrenched pathogenic orientation mindset is posed as a barrier, it is so important to realize that both the pathogenic as well as salutogenic perspective, they are actually complementary. And the application of both actually provides an all-rounded healthcare delivery. So after all, the synergy of both salutogenesis and pathogenesis, they reflect very real-life processes that we have, because we have both positive health aspects as well as negative health aspects. So in other words, having to treat the disease is as important as treating a person's stressors as well as coping capacity. So rather than seeing as a barrier and having to overcome a challenge, like what Prof. Gil has mentioned, it's about increasing awareness of salutogenic practices. How can we go about implementing it in our everyday work itself? And that's why it's important to share with our future nurses as well as existing healthcare professionals on the embracement of both perspectives. They are just equally important.
Okay, thank you, Bessie. Okay, I think still a long way for us to go. Yeah, so we just actually start to have this salutogenic model or salutogenesis. I think thanks, Prof. Gil, actually to bring this concept into our department. We are not only doing research, but also bring this into our curriculum. But of course, I think it's still a long way to go. We have to really to learn from each other. Thank you again for the three speakers for your wonderful presentation. So I think I will just end this session. Thank you, everyone. Thanks for your participation in this webinar. Okay, we are looking forward to seeing you all in next webinar. Thank you all.
Up in my head, fear's got a hold of me. Pretend I'm not scared of who you call.